All right, Billy.
All right, that takes us to Article 6.
Let's prevent cooties.
Infection prevention in the ED, and it's by Stephen Liang, and Jay Scher makes another show up on this. And so this is a big sort of review of all the things you can do to prevent infection in your emergency department.
Big review.
It's a bit of a bore, with all due respect to the authors. I love you. It's September 2014 in the Annals of Emergency Medicine. It goes through the whole thing from top to bottom, from ass to tea kettle, about what you can do, including hand washing, et cetera, et cetera, et cetera.
All right,
and
so
let's just jump in, and we're going to go quick because there's not,
a lot of the stuff you know already.
Yeah, there's not a lot of new news in here, but let's do it. Challenge to infection prevention. No kidding. We got tons of people, high traffic area. A lot of them are sick. That's why they came there.
Cesspool of medical stuff.
Patients may bring in and or acquire infections in the ED, and this is an article that reviews the various practices for prevention. To set up for transmission, millions of visits per year. It's the portal of entry for almost half of admissions, and in many hospitals, 80%. It's busy, crowded, patient waits, evolving diagnoses. Oftentimes, I don't know. It's the front line for public health events, and that's sometimes a pet peeve of mine. We're asked to screen and do all kinds of things that are sort of contrary to our primary mission.
But you couldn't set up a better system to pass infections around than our emergency departments.
Yeah,
that's true.
Except for an airport.
That's true.
Infections are problematic for patients and healthcare personnel. And so let's jump into it. Let's talk about hand hygiene and singing, happy birthday ×2. And so Semmelweis discovered the importance of hand hygiene in preventing transmission of infection with obstetric surgery way back when. Single most important strategy to curb transmission of infectious organisms
is washing your hands.
Healthcare providers acquire transient flora from the patient environment as well as the normal colonizing flora. And proper hand hygiene eliminates the transient flora and decreases risk of transmission. To get my license in New York, I had to pass a New York State hygiene control module and pay $40 to the Nursing Association to review hand washing. So hand hygiene programs dramatically reduce hospital-acquired infections. And you can use the alcohol-based gel and foam, and they have them everywhere at Stony Brook.
As they should.
And so it's a lot easier. They have them way more frequently placed than they do at LA County, for example. And so most of this recommendation is for routine hand hygiene before you go into a room. And the foams are easy and they improve adherence, and especially if you have them everywhere.
Before and after, right?
Right, before and after. Soap, scrubbing, and rinse, because when you don't do it after, you sometimes forget before you go in the next. So it's before and after. And in some places, Diane can tell us that even touching an EKG, didn't you have
the
EKG-related cooties at Arbor?
We got dinged for that.
Yep. Now, they do point out here...
environment.
Right, and this is the kind of thing that might come up, which is that soap, scrubbing, and rinsing is preferred when you're talking about C. difficile and the spores therein.
Which is kind of
everywhere.
And
that the alcohol-based gel isn't effective. So if they ask about C. diff, you got to wash.
That is a good question.
It would be.
Topic.
Hand hygiene should be done whenever you're going to enter the 3-foot space around the patient. Adherence in lots of papers is all over the place,
terrible.
10 to 90%. Rick Picotto, we're at his home recording right now, but I remember Rick saying, I actually calculated it out. I'd have to wash my hand 230 times in a shift.
Probably.
And there would be no time for anything but hand washing. Interventions to improve practice have had variable success: education, reminders, feedback, administrative support, and in New York, law. And it shows up as a violation of professionalism if someone reports
Which actually, to be honest, makes some sense. I mean, and the gels have made it at least easy in and out to do it.
So up to 2/3 of ED procedures. Now we're talking about standard precautions when you're doing a procedure, and emergency medicine was notorious for doing things barehanded and cowboying it and things like that. And those days are clearly over. Standard precautions, previously called universal precautions, are aimed to minimize this. Gloves, protective gowns, masks, and eyewear. It's been extensively studied. Makes a big difference in some things, particularly like central lines. These should be used in situations of potential exposure to infectious material, including eye protection. I like the face shields better than the goggles. Use in cases of potential splashing or sprays of blood and body fluid. And all of us have had a chest tube spray at us when we didn't realize it was under pressure, or an LP fluid shoot out the top,
Just
or things
had that
like
happen,
that.
Actually, out the needle.
or you're brushing off a wound and a little arterial bleeder right in your
Get
face.
that lovely sort of pattern all over
get
your...
that, right. Practice of using personal protective equipment, PPE, is highly variable. Again, big range. People are most likely to wear gloves, but the effort of putting on the gown and the other stuff is not so good. So
Well, and
lots of
the
places-
gloves go from the patient's bedside to the keyboard,
Yeah.
right, in the room. It's
Right.
like, oh,
And so now, for example, a lot of trauma alerts, you really have to have your PPE on even to go in the room, and that's one of the things that's improved compliance. When studied, there are many barriers to use that are cited.
Yeah, it's what
Lack
we
of time,
want,
I just
yeah.
mentioned, perception of the patient being low risk. Obviously, this is hard to predict. Interference with dexterity and technical skills, and some of that is true. The better gloves
Yeah.
are better than the crappy gloves. Poor access at the bedside and uncertainty within which PPE should be used in which situation. So those are the barriers. They're out there. Many interventions have been studied. Again, the authors recommend ready access, education and reminders, routine adherence monitoring, reiteration that gloves are not a substitute for hand hygiene.
right. So that's all the standard stuff. How about
Yep.
transmission stuff?
So now we're going to get into the difference between, what kind of airborne precautions do you need. So airborne droplets are large particle droplets and direct contact.
So there's three kinds, right? There's
Right.
airborne, there's droplet, and then there's direct contact.
Right.
So,
Airborne droplets are the biggies. Airborne precautions, droplets less than 5 microns can remain suspended in the air and infected for hours. So these are problem ones. TB, measles, SARS, varicella, things like smallpox. These require clinical suspicion and early isolation, and there are screening tools available of varying value. This paper obviously came out, Ebola gets talked about now.
right.
And
I
these
mean, one of the
things as
screening
well.
tools came out of our institution. These are the things that are small enough that they hang out, and so you need to
Hang in
protect.
the air.
They hang in the air, and so this is airborne. I think the terms are important to help because this is a guarantee. This is one of the questions.
Yep.
So airborne is the tiny.
droplets,
yeah,
not the
and
large
I'm going to
ones.
take the droplet word away because the next one is droplet precaution. So
correct.
airborne is these tiny particles
Suspended.
that suspend in the air, and so you have to keep those filtered away from you and from the patients for a while. So that's the TB, the measles, the SARS, that stuff.
Right, and I had my TB turn positive when I worked at
You
LA
did.
County, and
I
I
still
had to take
haven't.
the INH, and I believe, of course I don't have proof of this, that I didn't get it at work.
Oh, it's always possible. You live in LA.
So no, I think I got it at ASAP. So I went to the Seattle ASAP, and then I went to go hiking the Olympic Peninsula, and on my drive out on the Olympic Peninsula, there was this Native American guy hitchhiking in a downpour. And I was like, what kind of scumbag could drive past this guy in the middle of the night hitchhiking in a downpour? So I picked him up, and I drove him an hour to the reservation out at the terminal point of the Olympic Peninsula, and the whole way he was hacking
Coughing.
pink bloody sputum
Oh.
into his bandana.
Seriously?
Yeah.
Oh, of course you got it from him.
And
You're
I was
lucky you
like,
didn't get multi-drug
in the
resistant.
truck with the windows up.
Oh dear, that's a given.
And that was shortly thereafter that I
Okay.
turned. There you go. So now we're to airborne,
Yeah, this is the same. So airborne, this is how
Yep.
you protect yourself.
N95 or a purifying respirator. And most people are using the N95 because that's the easier thing.
Tight-fitting ones.
There's poor healthcare compliance with their use, poor fit. I remember I've had numerous
test.
fit tests. Has led to healthcare provider infections, for example, during the SARS epidemic. So, these are
Including
out there.
some deaths.
Yep. This is to protect the healthcare providers. Negative ventilation rooms in the ED are useful, but most EDs don't have that many of them.
Yeah.
Just a few. In fact, I remember the discussion when we were building the new ED back at LA County was how many should we have? And we didn't want to have too many because we felt like they would then just leave them in our care because there were none upstairs. So, you get into these, unintended downstream results. Negative ventilation rooms in the ED are useful to decrease infection risk, improve respirator use. How do you do it? Availability, fit testing, and education.
Now droplets are different. from
Droplets are
airborne.
different. Those are the ones that don't hang in the air forever.
They're bigger.
This is someone sneezes on your face. The droplets are bigger than 5 microns. They don't travel far, remain suspended for long. And the examples of this are seasonal influenza, meningococcal disease. Every time there's a meningococcus patient, they want
freak
everyone
out.
to be taking it. H flu, strep, and pertussis. I recently was called by infection control at Stony Brook because I saw a pertussis patient, and fortunately we had sampled his chart from before, from his last, and knew he was pertussis and isolated him immediately. The infection control people were so grateful. Surgical mask is sufficient here, so now you don't need the N95. Just a little surgical mask is good. Recommended when working within 3 feet of the patient. Some suggest a little further, and it depends on whether they're big sneezing, snorting, spewing. But if they're not, 3 feet's probably fine. If they are, then, think about
It's
it.
your trajectory. How far do they sneeze?
Single patient rooms are preferred if multiple spatial distancing and curtains will work, because the curtains do block the droplets from jumping around. Adherence by healthcare providers, again, fairly poor. Electronic health record reminders, if they only worked. When ordering flu testing may improve compliance. And I would remind everyone, wherever you see the words may, you could substitute may not. It just depends on how fatigued you are by your electronic health record, and it's constant alerting you of something or other. Some healthcare providers feel mask interferes with therapeutic interaction with patients. That sounds like a cheap, lame excuse, but there you go. Authors note that patients may play a role through educational signage, can voluntarily wear masks if they're coughing, can perform hand hygiene if the gels are available, and can use cough hygiene techniques. Certainly worth.
Sometimes people need to be instructed on the hand hygiene gel. However, we had a guy just a story of a friend who actually had noticed a patient's family member came out, filled his hand with the foam of the gel, rubbed it on his hands like this, and rubbed it through his hair like hair gel. So he used it like a hair product. So it actually is supposed to, although he got it on his hands that way, so it kind of did both.
Yeah, there you go. All right, now we're to contact precautions.
Right, so it's the third of the big trio.
The third, and important to prevent transmission of multi-drug resistant organisms and enteric pathogens. So this means gloves and gowns, right? So it's not going to get on your tie, your shirt, your vest, your hat.
Stethoscope.
Notice I used vest and hat in there just to
Yes,
make
because
sure my
someone wears
apparel.
vests and hats. Just saying.
Policies vary widely on their use. The HR flags of previous multi-drug resistant organism may improve and may not improve adherence. Healthcare provider vaccination can help with some of these things. So hepatitis B, measles, mumps, rubella, pertussis, varicella, and seasonal influenza. Got all those. Check. So I'm up to date on those. Influenza vaccination adherence among healthcare providers is variable unless you work at a place where they mandate it and they track you down. And at Stony Brook, they mandate it. But here was my beef at Stony Brook. The flu season, as many of you know out there, this year, was it early or late?
Late.
It was late.
And
they
it was
made
minor-ish.
they made me vaccinate very early, and those vaccinations sort of wear off a little bit. So I usually like to hold my flu vaccine until I've seen the first case or heard of the first case. So I felt like I got it a few months earlier. Vaccination does not replace hand hygiene and droplet precautions, just to be clear, because the vaccination isn't universally preventive.
No, and there's other things that get transmitted anyway.
Yep,
So.
there you go. So what other transmission-based precautions in terms of environmental control? Surfaces and equipment may become contaminated with organisms. So this involves the patient environment and their immediate vicinity. Healthcare providers may contaminate their hands during patient care and then spread it. Contaminated rooms may transmit infections to subsequent patients. This is all about room cleaning, equipment cleaning, and no equipment is getting more attention, and we'll get to it a little bit later, than the ultrasound machine.
I'll tell you, I mean, we start our shifts with using these wipes and wiping down every surface we touch in our doctor's room.
And everyone knows someone at their hospital who's got some obsessive compulsive behavior that they're out there with the
Stick 'em
chlorine
on
wipes,
this.
doing all the phones, all the computers.
It's good.
I do appreciate it. I don't have that particular obsessive compulsive issue, but there you go. So what are the CDC guidelines for disinfecting? There's low-level disinfection between patients of non-critical equipment like blood pressure cuffs, environmental surfaces in contact with the patient's skin, bed rail, patient furniture, and floors. So they do all that. That's your environmental services. And then in terms of environmental controls, there's guidelines for disinfecting, so routine cleaning. And then MRSA isolation is another one that comes up. We all know we're in the middle of the MRSA epidemic. It's not really an epidemic. It's just part of our world now.
Everywhere, yes.
So it's found on stethoscopes, phones, computer keyboards, doors, and keypads. Unclear if transmission can occur from these objects, but disinfection seems prudent. Seems prudent.
Seems prudent. It
To
does.
get to Saturday Night Live. would be prudent. Hospital-acquired infections is another thing that occurs in the ED setting, and we should be conscious of these. 1 in 20 Americans will develop a hospital-acquired infection during the course of their hospitalization. Claims 100,000 lives. Wow. Healthcare providers should focus on preventing patients from acquiring these infections. And they note that speaking of which, and the ED is a high-risk
Droplet
environment.
precautions.
And I'm spreading it to her via the
Yes.
mouse right now.
That's right.
ED is a high-risk environment for patients to acquire such infections. So one thing I mentioned already, central line-associated bloodstream infection. You know, these are started often in the emergency room. They can extend the ICU stay. There's high cost. They increase mortality by up to 30%.
That's amazing.
Ouch. So there's some heterogeneity in these studies, but one study suggests rates are similar to those in the ICU in an academic medical center, meaning we have to do the same level of precautions and cleanups. We've got to glove, gown, drape appropriately. So adherence rates, again, for this are not so great. Lower
Especially
rates
among
among
the
senior
senior
physicians. I guess I'm there now. I don't like to think of myself as a senior
It's official.
physician.
It's official.
Simulation, where you make people do it, even in the sim lab, improves adherence and decreases the rates of these infections. There are some successful ICU strategies in terms of comprehensive bundling, the chlorhexidine alcohol skin, and avoiding the femoral vein because it's just a little dirty little area down there in the groin. You could do better than that one unless you have to. Standardized equipment carts, checklists, and observers useful. Unless I need an observer. You contaminated the
You imagine being Billy's observer.
Oh,
I
man.
can't imagine being your observer.
Outcomes of implementation of ICU-style strategy have not been studied in the ED. Thank you for noting that. Early discontinuation of central lines placed in the ED has also not been studied well.
Yes.
But I can remember when I was an intern
Changing the line.
on surgery, whenever a patient came up from the emergency department with a central line, the very next day in the rounds, I would be told, those are enemy lines.
Yeah,
Get
change
them
the
out.
line. Yeah, it was great.
Change the line.
Our interns always got tons of lines that way.
Those that came from behind enemy lines. It's got to be done. Peripheral veins are not such a big deal, but they can have issues with thrombophlebitis and things like that. And more than half of all infected peripheral veins originate in the ED, according to one study. Thank you for
We spit on them first.
drawing attention to the regulatory forces to us. Adherence to aseptic technique and other catheter care is poor in the ED, and so they recommend educational programs, direct observation, feedback. I'm telling you, the regulatory do-gooders.
They're having fun with this paper.
Oh,
It's like,
man, they've just gone crazy with this stuff. And I get it. I'm not saying I don't believe in the germ theory, but the regulatory spew and explosion that is associated with this has just become nightmarish. I mean, how many times do I need to be fist tested? How many times do I need,
Yes, I know. I'm with you.
Don't get me started.
I'm with you.
What are the other recommended strategies regarding lines in the ED? Don't start them if they're unnecessary. Ultrasound-guided peripheral access may save you central lines. That's true.
Right. That's probably why it's helpful, but I'm not sure. I think it changes infection rate.
Right. So there you go. And now we're talking about the Foley, the CAUTIs, the catheter-associated urinary tract infection. There are all kinds of papers, and we've seen them in the emergency medical abstracts
Tons
and in
of
these
them.
venues. Didn't we do one of
We
these?
just did. Yeah, we did it this year.
Yeah. I thought we did one where they talked about their posting and had their sign in their
Yes.
program that decreased these a lot. And it was multidisciplinary, involved the nurses and the ED
Right.
docs to say, do we really need a Foley or not? And so urinary catheters may be started for inappropriate reasons, especially in the elderly. Many of them are for convenience. And with this, the severity of these infections, really the convenience Foley
Right.
has to stop.
Yeah.
And nobody really wants a Foley. Everyone hates getting one placed. About half of catheter-associated urinary tract infections in elderly occur in settings of inappropriate use of the catheter. Youch.
There you go. Get rid of half of them.
So that's obviously coming to bear on us. It's awful. These catheter-associated urinary tract infections have been described as never events, which is clearly crazy. Some people need
one.
Foleys, and some of them are going to get infected. And so, calling them a never event to me really misses the mark and alienates the medical community. It's unfair. How can we reduce them? Educational programs with mandatory checklists, things that challenge Your need for a Foley will reduce Foley catheter insertions by up to 80%, and also increased appropriate use in physician order documentation. So it used to be the nurses could kind of do these on their own
And say, "Can you drop it
and
over?"
then say, please cover me with an order, or it was just part of their individual decision making. Those days are gone for sure. Now we move on to the next device, ventilator-associated pneumonia, defined as a pneumonia developing more than 48 hours after mechanical ventilation that was not present at the time of intubation. Big time morbidity and mortality associated with these. Trauma patients are, and increased ED length of stay are risk factors. So again, pointing out that our area is dirty. There's all this interesting science around these surrounding bioslime
Yeah.
and its adherence.
Bioslime. I love the term.
The bioslime.
Bioslime.
Apparently, the emergency department is a center of excellence for bioslime. And so we're sliming people and they're getting ventilator-associated
is, actually.
pneumonias. So what are the guidelines to decrease this? Focus on minimizing aspiration of secretions, reducing airway, bacterial colonization, preventing contamination of the mechanical devices, and ICU nursing interventions. And I thought about this. We don't always put their head of the bed up 30 degrees, but we should. Oral hygiene with hydrogen peroxide. Have you ever seen it done?
Not in the ER.
Never seen it done.
Done every day
Here
in
it is in the
ICU.
recommendations. What do you do? Just pour a little bit in there and
I think
yank
they, no,
it
they
out?
clean it. I think they have to clean their teeth. They wash their teeth. The main is to get that oral flora
It's all about
minimized.
the bioslime.
Bioslime.
ED prevention of ventilator-associated pneumonia should consider including interventions studied in ICU.
Just like you were just saying.
Just like for the other stuff. Early extubation is appropriate in patients, and the ED may also be useful, but not studied. And I'm often loathe to extubate.
Not in the
I mean,
ER,
I have
unless we have to.
extubated many
Yeah.
patients in the ED. I'm not saying I don't do it, but I'm loath to do it for a variety of reasons. Other medical devices,
There's the
and there's the
ultrasound
ultrasound machine, and boy, they come in looking at those
my
ultrasound machines. When they find a blood-caked ultrasound probe, they
It's so disgusting, though.
they have a-
It
they
is
have a
so
cow.
disgusting.
they have a cow over that.
It is amazing how often it's gross, though.
MRSA isolated in up to 70%. Adequate disinfective practices with antimicrobial wipes. So you really got to pay a lot of attention. And we had Deco Mandavia at LA County, who was
Right.
the ultrasound monitor and hawk. And for years, he went around. Anyone who put an ultrasound probe down without cleaning it after they done with the procedure,
He
he
should,
would
though.
just
And it has
explode.
little nooks and crannies and little edges of the probe, and it's nasty.
Yep.
Now, this
Yep.
one, this one. So HPV.
Yeah, has been isolated in up to
HPV.
21% of endocavitary probes.
Oh my
Ugh,
goodness.
yuck.
Genital warts, 21% of probes.
Wartation.
Oh my word.
Even if using covers and low-level disinfection.
Oh, that's so nasty.
Yep.
Okay.
Because these probes contact mucous membranes, high-level disinfection is indicated between uses, and they are beginning to enforce it
Well, they
on
should.
these surveys.
So if I were the patient, I'd clean it myself.
There you go. Yeah, could I have some wipes and a half
Some
an hour
wipes.
alone with the probe? Don't ask.
Yeah, just go on.
Yeah.
Keep talking.
Okay, so what are the future directions when we talk about this? And one of the future directions is, that the authors don't talk about is just we're going to have the living bejesus regulated out of us with people examining our practices and looking and checking us. And
This is low-lying fruit, and we don't do it right. So there you go. It's
so-
a win-win for them.
so they're going to go after us. But the other future directions are research on prevention of infection in the ED needs to focus on the myriad reasons. Yeah, we got it.
Myriad.
A comprehensive, multifaceted approach is most likely to be successful. Groan. ED participation in hospital infection prevention committee is encouraged. I'm sure there's a junior faculty that can do that. The electronic health record may not prove to be a powerful tool because it's alarming me for too many things.
Right, it's alarm fatigue.
The idea that the EHR is going to solve this problem, let me help you here. That's not a future direction you ought to be
No.
going in. It won't work.
It's too bad.
I
No.
appreciate your thoughts that the EHR will solve this like so many other problems. Increased likelihood of adherence in areas to address, making PPEs readily abased, getting the alcohol little scrubbers all over the place. Critical infection prevention supplies, like I don't know where the hydrogen peroxide is, and I've never seen someone put it in anyone's mouth. Communication, reminders, observation, monitoring, checklists, institutional
Blah-de-blah-de-blah.
commitment, and ED design.
Yes.
ED design is something that I'm interested in. The fact of the matter is, though, even if someone comes up with some great new ED designs, they won't be put in place until someone's building new hospitals. So there you go. So limited impact. More of the future rapid identification of potentially infectious patients would be useful, and maybe some rapid tests, PCRs and stuff could do that. I just see it as being hugely expensive, but because it's a screening test now.
Right.
Overcrowding needs to be addressed.
Good luck.
Don't make me have a seizure. Really?
Of course.
Really? This is what's going to this is what's going to allow
Although
us
if
to deal with
infection
overcrowding?
control, it makes them get the patients out. I'm fine with that. If it's the hammer we need for that, I'm good with
No,
that.
they'll make more negative pressure rooms as
know.
they deal with it.
I know.
Research is needed on optimal cleaning of the areas. Okay.
So to summarize.
Hand hygiene. Alcohol-based gel for most stuff, but not for C. diff.
Good question.
Do it if you enter the 3-foot space. Standard precautions used to be called universal precautions. Gloves, gowns, eyewear, masks, indicated at any time there could be stuff splashing around. Airborne precautions, measles, SARS, TB, varicella.
Small particles.
Small particles. Stay suspended. You need the N95. Oops, I dropped one.
And one more.
Yep.
There you go.
Droplet precautions, seasonal flu, meningococcus, H flu, group A strep, pertussis, surgical mask. Now you don't need the N95. Use within 3 feet.
Good question material. This is
Good question
they're gonna
material.
Go crazy on this.
Contact precautions, gloves and gowns, important to decrease transmission of multi-drug resistant organisms, primarily MRSA, but also the enterics. Healthcare provider vaccination, do it. It's good for you. It does not replace hand hygiene. Environmental controls, cleaning the environment, also involves the healthcare provider area and equipment.
Clean your stuff.
In terms of central line associated infections, they do increase mortality. Bundles, carts, checklists, gown up, glove up, drape up, prep the skin. I always used to yell at the residents, betadine is cheap, infection is expensive. Clean the area, drape it appropriately. Cauties from the Foley, minimize the use. Ventilator-associated pneumonias, variety of measures, including that hydrogen peroxide in the mouth that I've never seen.
Kinda cool.
Other medical devices. Ooh, the ultrasound machine. You've got to clean that puppy. HPV 21%. That stuck in your mind, didn't it?
I just think that's nasty.
Didn't that stick in your mind?
Oh, these poor
21%.
patients. Who knew?
Yikes.
That's yuck.